Review at www.ctchestreview.com. This is Dr. Bhavin Jankaria, and we're looking at the 111th case over, I think, now 3.5 years, maybe even 4. So today it's the case is titled ILD with cysts in Sjogren's disease, and many of you must have already guessed what the answer is. But this is a 59-year-old known to have Sjogren's disease, presented with diffuse lung disease. Please look at the images. We've got 6 starting from the apex to the base. And my question to you is, which one is this? UIP, NSIP, OP, or LIP? Now, these are all patients with Sjogren's disease. This is a UIP pattern with honeycombing, traction bronchiectasis, subpleural basal involvement, and reticular opacities. But see the sharp margins that typically occur with connective tissue diseases. But this is a Sjogren's with a UIP pattern. This is an NSIP pattern, reticular opacity, subpleural sparing on the right, traction bronchiectasis, no honeycombing, and no ground glass. This is an organizing pneumonia pattern. This patient presented in 2017. We didn't have a diagnosis, came back after the COVID pandemic with progression. I biopsied it. It didn't show malignancy. One of the things was to rule out lymphoma, and then was diagnosed to have Sjogren's, and the patient improved with treatment and you can track it on the radiographs. I wrote this up. It was one of the first cases that I did about when we started the site. So if you look at our index case, we have reticular opacities. They show a peribronchovascular or axial distribution. We have ground glass. We have traction bronchiectasis. And then the hallmark or the most prominent finding here, the presence of these multiple thin-walled cysts, many of which are perivascular. So this is therefore lymphoid interstitial pneumonia, or LIP for short. LIP is an uncommon disease. It occurs predominantly with connective tissue diseases, and in that group of diseases, most commonly Sjogren's, and then in other immune dysregulatory conditions like HIV, AIDS, and CVID. Just to get a sense, here are the 7 common connective tissue diseases. Here are the patterns of lung involvement. The dark green is LIP. And you can see it's just a sliver in patients with RA and mixed connective tissue disease. And then it's a little larger here in patients with Sjogren's disease. But it's still less than UIP and NSIP. So if you look at LIP, it occurs in connective tissue diseases. Commonly, the archetypical condition being Sjogren's disease. It also occurs in patients with RA, SLE, and mixed connective tissue disease. If the picture looks like LIP, then Sjogren's is the commonest possibility, followed by other CTDs, HIV, AIDS, CVID, and other immune dysregulatory conditions. But remember that even in Sjogren's, NSIP is the dominant finding, followed by UIP, and then LIP and OP. In some series, LIP and OP have an equal incidence and prevalence, whereas in others, LIP is commoner than OP, and in yet others, OP is commoner than LIP, and there is a strong female preponderance, as you will see in the cases that I'm showing as well. Pathologically, you get a prominent lymphocytic infiltration of the parenchyma, and you can see that there's widening of the septae, nodular lymphoid aggregates. It's actually a lymphoproliferative pathology. Follicular bronchiolitis is an earlier form where you just get peribronchial lymphoplasmacytic inflammation. It's a tough diagnosis to make radiologically, even though FB is considered an earlier stage of LIP, but that's on pathology. Cyst formation is likely multifactorial. All these causes are here: vascular obstruction, post-obstructive bronchial ectasia, and perhaps bronchial compression by lymphoid tissue. On CT, cysts are the hallmark, and the vast majority of patients with LIP have cysts. please understand that when we are reading cases, it is not possible to diagnose LIP if the scan doesn't show cysts, because you can have LIP without cysts pathologically, but there is nothing on a CT that will allow us to make that diagnosis. So we get reticular opacities and ground glass, often with a peribronchovascular or axial distribution, with traction bronchiectasis, and then cysts, and you may have centrilobular nodules as well. So here's another patient. We have reticular opacities. These are predominantly in the basal regions, but you also see them here. There are lots of cysts. There is generalized increased lung attenuation. And in the basal regions, there's some traction bronchiectasis. This patient had a whole history of TB, so we've got post-infectious findings in the right apex. So all of this is very typical of LIP in a setting of Sjogren's disease. I've taken this from this review article that came in the European Respiratory Review in 2016 that just summarizes the various chest, various areas of involvement that we get in the chest. So ILDs, here you can see NSIP commonest, followed by UIP, LIP, and then OP. You also can get bronchiectasis and infections, and then here we have amyloidosis and lymphoma being complications. Now here's another patient with Sjogren's, has all these cysts, so we know we're dealing with LIP. You also have reticular opacities, traction bronchiectasis, but without cysts, we would have said this is a fibrotic NSIP pattern. But like we get overlap patterns, we get mixed NSIP OP, we get mixed UIP OP, and I suspect sometimes you also have a mixed NSIP UIP pattern. Is this just LIP, or is this a mixed LIP NSIP pattern? We don't know, but I would at least say that this patient has LIP. What when there are only cysts? So here we have perivascular cysts in a patient with Sjogren's, and there were a few articles in the late 2010s that said that perhaps cysts of Sjogren's don't necessarily count as LIP, because LIP is an interstitial lung disease where we must see other interstitial signs or signs of an ILD like reticular opacities, honeycombing, traction bronchiectasis, etc. But now I think just the presence of cysts in a patient with Sjogren's would qualify this as LIP. Here's another patient, 42-year-old. Everything else is normal except for the cysts. And if this patient didn't have Sjogren's, we might have even tried to consider the possibility of lymphangioliomyomatosis or LAM. But in this case, you would just call this LIP. Can you have a rare patient who has Sjogren's and LAM? It's always possible. But you think of zebras only in Africa. Okay, I didn't get that correct. Complications, we have lymphoma, amyloidosis, infections, and TB, which in an Indian setting can occur with any ILD. Now, this index patient of ours had a right middle lobe opacity with air bronchogram. So is this pneumonia? Is this lymphoma? At least we need to flag this in our report, and this patient needs to be worked up. This is a 70-year-old with Sjogren's who has these calcified masses throughout the lungs. These masses are not within the cysts, but you can see the rest of the manifestations of LIP with cysts and interstitial lung disease. So is this amyloidosis, which I thought was more likely? Could this be lymphoma? That's possible as well. The patient refused to get worked up, so we never actually got an answer here. I did talk about the many phases of lung lymphoma in case 78. In case you're interested, you can go through that. Now, this patient has classic LIP findings. You've got reticular opacities, traction bronchiectasis, ground glass. Here's the axial peribronchovascular distribution and cysts, but you've also got these calcified nodules, many of which are within cysts. And cysts with nodules within the cysts, some calcified, point towards amyloidosis. But again, the patient has opted actually not to do anything. I did talk about this entire so-called pathognomonic finding again about 2.5 years ago, and that's the URL if you want to go through this case and a couple of others as well. And then this is a patient with Sjogren's NSIP who developed in August 22 these areas of consolidation or extra opacities in the left lower lobe, which then turned out to be tuberculosis. And then with treatment, they regressed as well. So LIP is a rare disease, and it's a rare ILD. Idiopathic LIP is even rarer, and hence a diagnosis of LIP on HRCT should only be made if the patient has Sjogren's disease, HIV, or other immune dysregulatory conditions. In the absence of these findings, as a radiologist, I don't think we should be talking about LIP at all. The hallmark of LIP is cysts, and even though LIP without cysts can be diagnosed on a biopsy and pathologically, we as radiologists cannot make that diagnosis. Period. So you need to have those cysts to say that it's LIP. And every time we see a patient with Sjogren's, with interstitial lung disease, or sometimes even without, we need to be cognizant of the fact that these patients may have superadded infection, especially TB in our country, amyloidosis and lymphoma, and look for these. And if patients are coming for serial follow-ups, then look for those subtle changes focally that can flag these as well. Don't forget the table of contents where we have all of these things available for quick retrieval. That's my WhatsApp channel. For those of you who'd like my other sites and cases, I did the SALT update 10 days ago. That's my book. The last biopsy case was temporal bone biopsy. I just put up this case 4 days ago. If for those of you who like these bone and soft tissue challenges, thank you so much for listening to me. You know where to email, comment, subscribe, etc.